This is our first question that we're going to actually pose to the audience. Dr. Patel, you want to ask this question?
Sure. So, when considering all the immunotherapy options we just discussed, and of course some of the exciting clinical trials coming up, in a patient with advanced melanoma, which of these underlying other conditions would not be a contraindication to treatment with immunotherapy? So would it be psoriatic arthritis in a patient on infliximab and methotrexate? A heterotopic kidney transplant recipient who's taking tacrolimus and prednisone as anti-rejection therapy? A patient with Hashimoto's thyroiditis who requires levothyroxine and Levoxyl replacement? Or a patient with ulcerative pancreatitis who intermittently needs therapy with mesalamine and 5-ASA? So we'll give the audience a few seconds, few moments to answer this question and contemplate the responses.
Because we often get these kinds of patients, right, Dr. Patel, that come in and have other diseases, such as an autoimmune disease, or the immune system's already attacking the body.
Right.
So.
The issue is whether you would withhold immunotherapy from somebody who has essentially a life-threatening melanoma simply because they have an underlying autoimmune disease. However, it is also the idea of if you're stimulating the immune system and somebody's on therapy that may be blocking the immune system, how effective will that be? Or will you set them up for toxicity?
Okay, so why don't we go through the answer,
Okay.
Dr. Patel?
Oh, sorry about that.
Yeah.
So the answer to this case was actually C, and it's a patient with Hashimoto's thyroiditis who requires levothyroxine and Levoxyl. That would not be a contraindication to immunotherapy. If we go through the choices one by one, a patient with psoriatic arthritis who requires infliximab and methotrexate is actually on immunosuppressive medication. And so if their autoimmune disease, psoriatic arthritis, is so is in need of immunosuppressive agents such as infliximab and methotrexate, it may not be safe to give them immunotherapy. In addition, you may be negating the effects with their psoriatic arthritis medications. In a patient with a heterotopic kidney transplant who's taking anti-rejection medication, again, that medication, the prednisone specifically, is toxic to lymphocytes. And so if we're trying to surge the cytotoxic T lymphocyte, we may not be able to get that effect. Furthermore, we may enhance rejection of their kidney transplant. A Hashimoto's thyroiditis patient is simply on thyroid replacement, but those thyroid drugs are actually not immunosuppressive, and they have no ability to be cytotoxic or to kill off the lymphocytes. And in a patient with ulcerative pancreatitis who does intermittently require therapy, again, these are immunosuppressive therapies. But more importantly, pancreatitis is a condition that could be exacerbated with immunotherapy, from high-dose IL-2 to checkpoint blockade inhibitors. These drugs can cause an immune-mediated diarrhea or colitis, so it may not be safe to give it in a patient, particularly who requires immunosuppressive therapy, such as those.
So Dr. Patel, what would you do when you have a patient that comes in with a very serious metastatic melanoma, but also some autoimmune disease? How would you treat that patient?
Yeah, it's a really good question. I think, you first go looking for maybe actionable mutations in that patient, and maybe there's a way to treat them outside of using immunotherapy. There may still be a role for chemotherapy in patients like that, in whom immunotherapy could be potentially dangerous. But also you have to have a really important discussion with the patient that they have a very aggressive melanoma that could be terminal if it's untreated and unchecked, yet they have this underlying autoimmune disease. And if your back is up against the wall, you may have to bite the bullet to do that. Technically, the labeling of these drugs, though, would say it's probably contraindicated in patients who have significant underlying autoimmune disease.
We got an excellent question from the audience about pseudo-progression and that. How do you manage that? Because the tumor's growing. How do you know if it's growing for pseudo-progression or if it's growing because the drug's not working? And how do you treat those patients?
Well, I think that's an excellent question. That's a very real-world question. What do you do with somebody? I think you first counsel patients when they're getting immunotherapy. That when you do your next staging examinations, things may look worse, but if clinically they're not deteriorating, we're going to hang in there. And this is this phenomenon of pseudoprogression. Things may look worse, but if you're clinically not deteriorating, we may have the ability to just hang in there and get the immune system to wake up. But I think if a patient is clinically deteriorating and you're seeing signs of tumor growth, then you have to make the decision to consider switching therapy or augmenting that therapy. But I think this brings up a really good point of, the best tools that we use right now are radiographic imaging or visualization of tumors to just see if things are bigger or smaller. That's a very flat way of looking at changes in tumor. And dynamic radiographic ability is needed. So we need to be able to image a patient and image their tumor and decide if that tumor is enlarging because it's tumor or is it enlarging because there's T cells that are infiltrating, et cetera. So dynamic radiographic modalities, I think, are really needed in this era of immunotherapies as well.
So we have another excellent question about sequencing and choosing. There are many kinds of ways to treat melanoma now, right? Really exciting field. We have immunotherapies that we're talking about today. Next, we're going to talk about targeted therapies. How do you decide when a patient comes in to your office, which one you're going to start with?
Yeah, there is no cookie cutter answer really here, and I think the field is still finding its way. I think one of the things you do is you look your patient, you do the physical assessment of your patient, and you know there's observations we make about their performance status. We see how functional they are. Are they breathing, comfortably and naturally? How burdened are they by their disease? And in a patient who's asymptomatic with maybe a minimal tumor burden, because we know pseudoprogression is a real phenomenon, you're weighing the risk of the tumor or the scans and the clinical status getting a little bit worse before it gets better. So in somebody who's asymptomatic with a low amount of tumor burden, they may actually be able to tolerate a little worsening of their tumor. But in somebody who already is showing signs of organ failure, maybe symptomatic from their disease, has bulky, disease, they may not be able to have the time for things to get worse before they get better. And in that case, it may be better to start with something a little more aggressively cytotoxic and then transition them into immunotherapy.
What's your thoughts about the combination anti-PD-1, anti-CTLA-4 data that you showed? Do you think, I know that's still in clinical trial, but will that be better, or will it be better to do one and then the other in terms of a toxicity and benefit
Yeah,
profile?
it's a great question. And again, you saw data that showed with single agent checkpoint blockade, often the durations of responses are 2 years. You also saw data that showed prior ipilimumab does not preclude a response to PD-1 therapy. So while concomitant did show very powerful 1 and 2 year responses, we don't yet know how durable those responses are. It may be that we get 5 and 10 years out of combining the drugs up front. Alternatively, if you can do just as well sequencing them using one agent until its maximum duration, a couple years, and then sequencing on to another, in order to minimize the toxicity, that may be a way. So I think that the field is still out on exactly what to do, but I think it's a really exciting time to be looking at those questions.
Now, if a patient has ipilimumab, responds, and then later, several months later, the tumor starts to grow again, can you use the ipilimumab again?
Right, that's a great question. And right now the consensus guidelines do offer indications for reinduction ipilimumab. And so this would be in a patient who you gave induction ipilimumab to, either had documented benefit, was a documented responder, or at least was stable without clinical deterioration by week 24. It's about 6 months on therapy, right? But your therapy stopped 3 months earlier. So if the patient is stable for at least that period of time, if they recur or progress after about week 24, again, without clinical deterioration, and they were either stable or responding in the first induction go-round, you can really use reinduction, and you may get a second response or a second boost of benefit. I know you've done that with patients. I've certainly done that with patients, and it's really nice to be able to use that therapy again in somebody who did get a response and try to generate a second response.